Is welcome to all of you to our second Wednesday speaker series. I've never been to a doctor. The title of tonight's program is to address the healthcare access for Marshallese people in Washington State. I'm Ronnie Shure, and I volunteer as the president of the board of directors for Healthcare for All Washington. And tonight we'll be discussing health equity for Marshallese people here in Washington State. Dr. Robin Narruhn will address the structural barriers that they face and that many immigrants from across the world are facing. So just like me, you can volunteer for Healthcare for All Washington. Please consider joining one of our committees, our policy committee, our communications committee, our outreach committee, our fundraising committee. Or if you are just interested in a specific project or two, or just want to offer advice, please reach out on our website. And we'd love to use your expertise and your ideas. On this Zoom, we're using the chat, and we will be posting a link to our website where you can find the donate button. You can navigate once you reach that button and you can make a donation if you are able, but then you can navigate to a button that says get involved, and you can enter the area, choose the area that you want to assist in, and we will reach out to you and would love to have your participation. While you're on our website, if you are able to make a donation, be aware that every donation helps us move a step closer to universal health care. We've set a goal to raise $250 during this program tonight. You can go to the chat at any time during the presentation and make a donation, or go to the Get Involved spot. We also will use the chat to track any questions that you have. We will have a Q&A session after we finish the presentation, and then we will pull those questions out and answer them at that point. There also is a closed captions button. I think it's actually called AI Companion. You know, the times they are changing. So we've moved from closed captioning to an AI companion, and we will make that available. Well, there is a closed caption button. So that is available. If you click on that button, then you can observe that or see the closed captioning. I am participating in this Zoom meeting today from the lands of the Coast Salish peoples. Our efforts to achieve healthcare for people includes all peoples of this land and immigrants from other lands. But please take a minute to acknowledge the peoples in the lands where you are joining us from today. We acknowledge all the ancestral homelands and traditional territories of indigenous peoples who have been here since time immemorial. Our efforts to achieve universal health care include universal health care coverage for the Coast Salish peoples of this land, the land which touches the shared waters of all tribes and bands within the Duwamish, Muckleshoot, Puyallup, Suquamish, and Tulalip nations. So let's introduce our spotlight, Dr. Narruhn. Robin is a nurse researcher and associate professor. She earned her PhD in nursing science from the University of Washington and teaches as assistant professor at Seattle University now. Her research interests center on health equity in immigrant communities, and her most recent research explored the structural barriers for Marshallese immigrants who are seeking healthcare here in our state. We have been a part of organizations that have been working on that, including an action way back in 2018.
Mm-hmm.
Dr. Narruhn has participated on a number of groups that have helped make that happen. The Pacific Islanders Community Association. She is a member of the King County Board of Health, the Community Health Board Coalition of a number of BIPOC organizations.
Ronnie, I think you just got muted.
And I didn't touch anything either. Dr. Narruhn has been active in making and overcoming the barriers to provide healthcare to Marshallese people in our community. She's a member of the Pacific Islanders Community Association and is on the King County Board of Health, a coalition called the Community Health Board Coalition. She's a member of Farmer Frog, and maybe that's where I got muted. I got a frog in my throat. And she's also an active member of Washington Physicians for Social Responsibility, where she works on nuclear disarmament campaigns. She's the daughter of an immigrant of the Pacific Islands and is the mother of one. And as we work to achieve a true universal healthcare system, we must realize that we have to design a system that can overcome inequity in each groups, such as the Marshallese people. And tonight, we'll discuss the actions that we can take to do just that. So, Dr. Narruhn, if you want to add your slides and take it away.
Absolutely. Thank you so much for that welcome. And I'm going to go through this pretty quickly because I'd love to talk to you all. And here we go. So again, my name's Robin Narruhn. I'm a member of the Marshallese community here in Washington State. And I did some research several years ago to try to understand access for Marshallese people here. And if you're wondering where the Marshall Islands are, they're basically in the middle of the Pacific Ocean, very close to the equator and the date line. So they're kind of right in the middle of Oceania. And the reason this is important is because there are more Marshallese immigrants coming to the United States. In fact, about 1/3 of the population has migrated to the United States, which is a large number. And you'll understand a little bit more later why that's happening. And we've immigrated in pursuit of economic opportunity, education, and access to healthcare. Which is fueled by very high unemployment and inadequate infrastructure in the Republic of the Marshall Islands. And Washington State has the third largest population of Marshallese people in the US. The other states that are very high is Hawaii, which makes sense, and Arkansas because of their employment opportunities there. So some of the background is that there has been a tremendous amount of colonization there by 5 different countries. There's been nuclear testing. There's been environmental impacts of nuclear testing and climate change. And I'll go into this in just a few minutes. There are incredible health impacts from the nuclear testing and climate change. There's also a lack of disaggregated data, which it makes it really difficult to ascertain what is exactly going on. And then, of course, there are great health inequities in my community. So if we had time, I would go to this video, this short video, but maybe you can do this on your own and watch just a trailer for Nuclear Savages. It's horrifying to watch what actually happened in the Marshall Islands between 1946 and 1958. And I'm here to tell you that what happened, it was not a one-time thing, that the effects of that are lasting 70, 80, 90, well into the future with our health inequities. So 70 years ago, 2 nuclear bombs were dropped on Bikini Atoll, setting off 12 years of detonation in the Marshall Islands. And from 1946 to 1958, there were 67 thermonuclear and fission devices. And if their combined explosive power was parceled evenly over that 12-year period, it would equal 1.6 Hiroshima-sized explosions per day. I want to pause and just let you read that or hear it again. If their combined explosive power was parceled evenly over that 12-year period, it would equal 1.6 Hiroshima-sized explosions per day. And yet most people don't hear about the Marshallese. Many people don't know where the Republic of the Marshall Islands are, or who we are, or what happened. That's called erasure. We were told that it was for the good of mankind, and that if we allowed these bombings, it would prevent all future wars. And I'm here to ask you, how has that worked out? These are photos of military personnel examining children who have been exposed to the radiation and more. You can see by this slide that this was medical experimentation. This is historical trauma. So obviously there was a loss of way of life. Our social norms changed, self-sufficiency decreased. We could no longer eat the fish or grow vegetation because everything was radiated, exposed to radiation. Sustainability was lost. Diet changes happened because we couldn't eat our traditional diet. I will tell you that Spam is not indigenous to the South Pacific, and it's very difficult on your it's a poor food choice with a lot of adverse health effects. We had a loss of land. Our major island, our biggest island called Kwajalein was turned into the Ronald Reagan military base. We also lost land to the radiation and also to climate change. And so while we have a very small carbon footprint, we do feel the effects of climate change, especially in king tides, which wash over the islands. And this picture will show you what it looks like to have king tides wash over your islands. Our islands are only 3 to 7 feet above sea level. So any change in sea level is going to greatly affect us. And then the salinization of the aquifer has led to a loss of plant foods because there's too much salt and the vegetation no longer grows. Radiation of the islands and ocean has led to contamination of seafood, and loss of land and relocation on unsustainable islands has led to a tremendous amount of poverty and, frankly, increased dependence on aid, which is not how anyone wants to live. And these are some of the drivers to the immigration. The health outcomes in the RMI, the Republic of the Marshall Islands, include increased rates of tuberculosis, diabetes, hypertension, a lot of thyroid cancer, alcoholism, depression, Hansen's disease, as well as high rates of suicide and birth defects from radiation. Here in Washington State, Native Hawaiian and other Pacific Islanders have high incidences of obesity, diabetes, substance use, chronic hypertension, and a lack of preventative healthcare such as vaccinations and dental health, simply because we didn't enjoy this infrastructure in our colonized and militarized islands. Okay, and the reason I can't give you Marshallese data is because we are aggregated into data for other Pacific Islanders or even other Asian Pacific Islanders. And so when we disaggregate that data, we will see tremendous health inequities in my community because of this historical trauma. So for example, we know that the COVID rate was very high amongst Native Hawaiian and other Pacific Islanders. And I have this little piece of data here for you. 21,268 among Native Hawaiian and other Pacific Islanders compared to whites, which was 4,850, a change of almost 5 times. In Spokane County, we represent 1% of the population, but nearly a third of the COVID cases. And the reason we have a COVID is not because of our individual behaviors, our culture, or our genetics. It is simply epigenetic and some of the structural factors around policy that have affected us so greatly. So the health inequities, again, it's difficult to assess due to the aggregation of data into the Asian Pacific Island category. We are underrepresented in health research, and there's a tremendous distrust of research due to the history of medical experimentation. The lack of research and that research aggregation has masked health disparities and limited appropriate interventions, such as resource allocation and policy development. And in 2017, McElfish et al. Found that diabetes and cardiometabolic diseases are very high in our community. So I want to talk a little bit about policy that made these health inequities and why that's related to healthcare for all. So because of all this bombing and taking Kwajalein Island to make it into the Ronald Reagan military base, there was a agreement or a treaty called COFA. We call it COFA, Compact of Free Association. And it was an agreement between three nations, the Republic of the Marshall Islands, Palau, and Federated States of Micronesia. So COFA provided U.S. economic assistance to these island nations in exchange for U.S. defense and certain other operating rights, namely the Kwajalein becoming the Ronald Reagan military base. So COFA allowed citizens from these three nations to immigrate freely to the U.S. without health screening, and we could have access to healthcare benefits such as Medicare, Medicaid, Pell Grants, and other such benefits. However, at that time we were eligible for Medicaid. However, in 1996, under President Bill Clinton, under the Personal Responsibility and Work Opportunity Reconciliation Act, we were inexplicably dropped off of the ability to access health care. So we had very limited access to health care, and that's why the title of my research article was, "I've Never Been to a Doctor." So in 1986, we entered into the COFA agreement with the U.S. 1996, under the Bill Clinton's Personal Responsibility and Work Opportunity Reconciliation Act, we were excluded. We were able to get a Medicaid restored in the Washington State in March of 2018, and it went national in 2020. So although COFA migrants are not US citizens and are not eligible to vote, we do pay taxes, which is also known as taxation without representation. We serve in the US military in very large numbers, greater than per capita rates of US citizens. And the COFA Treaty, while it started in 1986, it was broken from 1996 to 2020 and reinstated in 2020. In 2024, there has been a renegotiation of that, and I'm not sure what is happening with that. This is a picture of us in Washington, in Olympia, signing Senate Bill 5683 to reinstate some benefits for COFA immigrants. So we did research because public health kept asking me to assist Marshallese people into follow-up care. The aim was to understand the barriers that Marshallese people face in accessing healthcare services. We did interviews, we were IRB approved. We had a small sample, but we still had a lot of findings, and used content analysis, in vivo coding, so that we could avoid any bias. There were two major findings: healthcare and access and equity were real problems. And that's so obvious. It's like, why did I do the research? But the other thing that was surprising, and maybe I was being naive, is that historical trauma and embodiment are still very much a thing in my community. We still have early mortality. People often die in their 40s and 50s, lots of anomalous cancers, a lot of diabetes, a lot of birth anomalies. So these were some of the things I found under the first finding, is that there's ongoing effects of radiation, repeated denial of services such as Medicaid, interpretation, insurance, and there's a lot of poverty. Historical and trauma was the second major theme, and we found that there was early mortality. People die young. There's a lack of knowledge and understanding of the Marshallese. People don't know who we are. There's structural discrimination. There's feelings of sadness and despair. There's some shyness and humility and almost a sense of fatalism, which makes sense if you view what has happened historically. So our findings illustrate that the consequences of broken promises and treaties, and despite the historical trauma and embodiment, there is sheer resilience, strength, and survivance of Marshallese people. So this is one of the reasons I'm here, is to say universal health care is extremely important. In one of my interviews, a woman with some bit of exacerbation, when I kept questioning her, said, I've never been to a doctor, because I was asking her, how do you treat an ailment? And it was all home remedies. A lot of my community use EMTALA, the Emergency Medical Treatment Labor Act, to access healthcare in an emergency room, but the ER is not going to take care of cancer, and it doesn't do a good job of taking care of diabetes. So that's why I support universal health care. It is so extremely important that we prevent illness by being sure that everybody can get primary and primary care, preventative care. So I would like to direct you, as Ronnie has earlier, to this Take Action Network, and for you to express yourself to elected officials and other decision makers on issues that are important to you. And you can go to this link to get more information. Here are some references, and I would like to end with just asking if there are any questions.
And we want you to put your questions into the chat, so please go ahead and do that. Thank you, Dr. Narruhn, for getting us started in this conversation. We hope that you will add some questions, and we'll try to delve into some of those details. I know you referenced that documentary, Nuclear Savages. It was horrifying to watch it. It kind of reminded me of that movie Dr. Strangelove, or How I Learned to Love the Bomb, or Stop Worrying and Learn to Love the Bomb, because it showed the denial by not just the military, who were paying attention to doing their job, but also our government officials, our own government officials, ignoring those issues. And I remember our efforts in 2018 to allow the state of Washington to provide Medicaid and certain basic support services for people from the Marshall Islands and Micronesia and Palau, and it was hard. People, and as you said, in your research showed that even though we were able to take a step forward, get some action approval, despite the US government's treaty denial, get some approval in Washington state, frontline healthcare workers still didn't understand who the Marshallese people were, didn't understand that these privileges are something that we were able to implement in Washington state. It was hard to get the healthcare system to pay attention to some of the, to a group like that are just building barriers around them. And I think one of the things that you either included in your article, or maybe it was in the documentary, was a quotation from Henry Kissinger saying, there's
Mhm.
only 19,000 of them. There's
Right.
not enough to worry about. Who gives a damn? I think that's what he said. And I think the government, our government really were a part of are a part of that cause. And I think we do that in several areas in our current healthcare system. So it's something we should overcome. So I've got started asking questions, but let's urge you to I urge you to add questions. It looks like we're starting to see some in the chat. And while we do that, I'd like to invite Peter Lucas, one of our board members, to come forward and talk about making a donation. I know there are new people at an event or at a Zoom meeting like this. You should know what, Peter will share some ideas about how you can support us. And if you've been around and haven't made a donation in a while, Peter will tell you how easy it is to do that. Thanks for joining us, Peter.
Yes, just bring the money to me in small unmarked bills and bags. Okay, that's how you contribute. Anyways, thank you, Dr. Narruhn, for that excellent presentation, which I thought was very holistic, comprehensive, addressing the relationships between health, trauma, environment, politics, and economics, and if the compelling necessity for universal healthcare. And that's our mission at Healthcare for All. And over the past few years, our organization has chalked up many legislative victories in Olympia. We were very active in the past few legislative sessions, and many of the progressive bills we supported, fortunately, we lobbied for, were passed. And if you want to find out what we've accomplished in the past few years, legislatively, go to the legislations tab on our website. Now, to maintain our momentum in this regard, it's vitally important that we meet with our legislators, grow our membership, educate the public, and mobilize our supporters to spread the word about universal health care to their families, friends, and most importantly, those in power in Olympia. Now, we can achieve those goals through the hard work of our lobbyists, Lonnie Johns Brown, a very seasoned and skillful lobbyist. In addition, we employ a communications specialist, and we're very active on social media. We conduct monthly webinars such as tonight's presentation and have meetings with civic groups, as well as host other kinds of events. Financial support of our staff, including Lonnie, our lobbyist, as well as our other activities and obligations, all require funds, which is why we are asking you to donate tonight and every night for that matter. Our goal is $250. Please go to the links in the chat or our website and click on the donate button. And you can make a one-time donation, but we would especially appreciate if you could make monthly recurring donations. So please donate so we can spread the word and bring about universal, publicly financed healthcare in Washington. And we know that we're making real progress, but there is still much more to be done, and you can help. Thanks so much.
Thank you, Peter. Thanks for alerting us, and keep watching the chat for that link to get into our website, and also add your questions, and we will be pulling that up. So let's get started with a Q&A session. Robin, so one of the first question is about other government compensation for radiation exposure, and maybe tell us how the government looked at the experiments or accidents or whatever terminology we have used to describe the exposure to people in the Marshall Islands.
Yeah, so RECA is the Radiation Exposure Compensation Act, and it's being legislated right now this year. And I don't know, in the past, Marshallese have not been included. So Hardy, I don't know if if we are being, but in the past, we've been told things like if you just sweep off the first inch of topsoil on the island, it will be safe to inhabit. And I'm not sure anybody would want to live on an island that has been exposed to radiation and just sweep the top layer off. That's it's so disingenuous. I almost laugh. If you want to know a little bit more about the effects of the radiation, Holly Barker has some really good content that you can read. So I don't know if they are included. I do know it's being worked on right now. The other thing is, if you go to I was talking to a gentleman last night at the Golden Rule, which is a boat that advocated and made exposure to what was happening in the Marshall Islands during the 1958 to 1962. They never made it to the Marshall Islands, but they did raise awareness. I was talking to a Marshallese man at this event where Golden Rule was coming to Tacoma yesterday. And he said that his mother had 3 different types of cancer, went to the Marshall Islands and was told that it wasn't related to the radiation exposure. There were only just a very few particular types of cancer that were eligible for compensation. So I don't think that there's been a lot of progress on that right now, but I don't have the latest data.
And certainly the documentary that you referred to really talks about how the government called it an accident rather than what it really was.
Right.
And the pictures you shared with us really emphasized or demonstrated the fact that the government was not responding as if this was something should be compensated before. It was because of the way the wind was blowing. It was because of the tides. And so it's important for us to be aware that there are things that our government can do, and that there's things that each of us can do.
Mm-hmm.
So next question is about epigenetics, like how does a certain population become, have genetic effects that show up a generation later that didn't show in earlier generations. It's almost the issue that I think this question is related to the issue you brought up about historical trauma. Certainly there were children that were born with malformations and died, were not, never lived, but that had immediate effects. But there are historical trauma that is still going on that affects people today.
Absolutely. So I'm not a geneticist, but epigenetics changes the methylation of the genome, the genetics, and that can come. We used to think everything was either nature or nurture. We thought genetics is what made you ill, but we now know that the environment influences our genetics through things like trauma, which will raise your cortisol response, which might raise your blood pressure or decrease your immune system, or maybe have your liver release more glucose, and so now you're running into diabetes. So that's how epigenetics could work from historical trauma. But I actually think that the COVID that happened in Spokane is because of structural factors, which, we have agency, we have the capacity to act on this, but structural factors like not having PPE for essential workers when COVID started, by having, we are very family oriented, and having large families is our joy. So a lot of us live in a house together. We're very multi-generational. Houses are very, very common. So you can see how COVID spread, especially since we were essential workers. A lot of us were essential workers and without PPE. And, you know, you are faced with the question of, should I stay home and protect my family or should I feed them? And that's not a decision anybody wants to have to make, but those structural factors about, you know, what benefits you can have, who can live with you, who gets benefits, you know, are all part of the COFA policy, and excluding us from that has caused the fact that, you know, while being 1% of the population, we were a third of the COVID cases. So that is all very structural. It can be amended or mitigated by political will and agency, but that has yet to happen.
And so several of the questions are about defining what the Marshall Islands are, what Micronesia is about. Can you describe other things or other islands and maybe the impact, while not directly a test site or on a naval base or army base, what is going on in islands surrounding that?
Right. So Guam is not part of the Republic of the Marshall Islands. It is its own nation. It is a very militarized island by the US. And you may have heard during the Trump years that North Korea was pointing their missiles towards Guam when things would become escalated. So Guam is very, very vulnerable to militarization. And that is very harmful too. You know, you don't have access, you don't have freedom. Yeah, I just can't say more. But basically in the South Pacific, there are three areas. Is Micronesia, which are the small islands like the Marianas, the Republic of the Marshall Islands, Federated States of Micronesia, Palau. And then there's Melanesia, which is like Fiji, like Vanuatu, and then there's Polynesia, which is like Hawaii, I think Tahiti. So yeah, there's three major ethnic areas of the South Pacific. But I don't know if Guam is Micronesian. They are not part of the RMI though.
Thank you. So I think it's important to realize where people are coming from. I mean, that's a way that we can connect with people, not just as hoping that healthcare providers will do it, but as fellow members of the community. So it's important to recognize that. There was one question about universal healthcare, and I, you know, I think I brought that up several times along the way. We consider our current healthcare system more of a marketplace, and we are participating in state efforts, national efforts, and kind of like a combination where there is a current national bill to allow states to do more than we've done in the past. So there are a number of things going on. So please check our website for that kind of information. So thanks for that question. So I hope, I don't know if you want to talk anymore about healthcare for all. We love to do that. But let me go on to the next one, which is, you know, in your study, are there behaviors of healthcare providers that have limited access? I think I made one particular comment, but I think your research showed that there's still barriers for people from the Marshall Islands.
Oh, absolutely. So, one of the things that happened, this is outside of my research, but when we finally got the COFA insurance cards, Marshallese would take them up to the clinics that they attended. And since they didn't recognize the COFA card, they would say, oh no, we don't take COFA. Not the staff not realizing that COFA is a Washington state insurance program that they should accept. And so because we've been told no so many times, whether it's, migration, healthcare benefits, even interpretation, we often don't have interpreters because we are such a small population. It's not worth it for the medical institution to hire a Marshallese interpreter. They're just going to use a phone interpreter, which is not as effective. So, clinician behaviors, one of the findings is that we're simply not known. Nobody knows who Marshallese are. So I would say that if you're a clinician and you're working with a lot of Marshallese, please get to know us, like watch Nuclear Savages, know some of the history. When I was working at an area hospital for many years, a high-risk labor and delivery unit, I was working with a lot of Somali women. So I learned about that culture, that history, because that history means a lot. I had to ask myself, why are Somali women coming to the United States and birthing here? And what are the concerns? There were a lot of concerns, just like in my community. Learn about that community and, try not to other them. I become very upset when I see that clinicians are like, well, why are you coming here with this, wound on your leg? Why didn't you come earlier? When they don't realize, like, they couldn't come earlier. They don't have healthcare access. And what I would recommend to clinicians to decrease barriers, I would suggest looking at structural competency. So there's a new theory that says many illnesses are the result of upstream concerns, like historical trauma. And knowing this about your client and not attributing it to their culture, their individual behavior, or their genetics, but knowing that there are policies in place that are preventing us from accessing healthcare, just like not having universal healthcare is a barrier. There are things we can do if there is a political will. So I would say, look at the structural competency website. There's a great website. There's training materials and, I'd be happy to talk to anybody. I'm actually have done that with Health Point in Auburn that serves a lot of Marshallese people. I teach them about, our history and infuse structural competency in there. Which, really looks at sort of the social and the political determinants of health. And if anybody wants me to come teach, or talk with their clinician group, I'd be happy to do that.
And so I think that's, can have a real impact. I think that's the work on this is just such a great example of working on health equity and how important it is and how difficult it is for healthcare providers on the front lines, and people can be turned away by the person taking this interview information if they don't understand if the patient doesn't understand what the question is. And your title of "I've never been to a doctor" really shows the fact that there's a cultural difference from people who didn't have doctors or who experienced the atomic nuclear testing in their homeland, and the only doctors they knew were the ones that were doing this research or responding to an accident or an emergency. I've never been to a doctor is such a common statement from people.
Yeah.
And so there are several questions about how can this happen? How can the U.S. break a treaty? What can we do to monitor and to make sure those things like that aren't happening?
I think, whatever population you work with, you have to know them. So, if you're in Arizona working with migrant people, you need to know what are the causes of the migration? Well, some of it is our international trade policy, right? It's not that people want to come here, but it's almost like we make the impetus for people to come. And I had somebody in Olympia when I was testifying on the healthcare bill. And he actually said to me, are you telling me that we should just let Marshallese people come here and get healthcare benefits? And I said, I saw red. I said, we absolutely would love to stay in the Marshall Islands. That's our home. But because of the nuclear radiation by the United States, because of global warming, because of militarization, because of colonialism, we have been forced to come here. And yes, you absolutely should give us health care because the causes of our health disparities are the radiation. So he was quiet right after that.
And
So
so that it's you talked about the fact that there not only are clear healthcare risks and historical trauma, but there are current social determinants of health, and this is a political determinant of health. There's more than just the every day-to-day environment that we're living in. These are political decisions, and we really need to be alert to that and watch for that.
So Ned says, what were the politics that caused breaking the original treaty? Well, I mean, greed, that's one thing, but we were told, I mean, we're a very small population, so I'm not sure it was entirely greed, but we were inexplicably, nobody knows why, we were dropped off of that. I think they simply didn't care. This is why I am very, even as a nurse and a nurse professor, a nurse researcher, I'm very interested in policy because you can't be at the bedside for 40 years and not see the same problems happening over and over. And we must address it at a system level. And to do that, we need to change policy. So we need to be active on boards, in community organizations, talking to our legislators, making noise, writing op-eds. There's so many ways to do it. This is one way right here. Because I want you to know that if a Marshallese person comes to your clinic or you're thinking about whether immigrants should be eligible for universal health care, absolutely. And these are some of the reasons why.
And certainly one of the lessons that we're learning in healthcare systems, certainly as an employee at University of Washington Healthcare at Harborview, we really focused on the fact that people, you need to pay attention to people, and you need to get them involved in finding out who they are and knowing if they're from, in this case, from the Marshall Islands, or if they have other healthcare barriers that are in their way, to ask simple questions to identify who they are. I think it was a nurse quotation that UW used in educating us, which was, people don't care how much you know until they know how much you care. And so that's where healthcare providers should start with patients, should start with each interaction. And it takes seconds. It takes small amounts of time to establish that groundwork, and it can be so meaningful.
Yes. One of the ways I did it as a labor and delivery nurse is by asking Somali women to teach me words. And so I learned maybe 20 or 30 Somali words, and I learned about their customs and their values, and it was wonderful. There are many ways to live in this world, and many beautiful ways that we can learn. I would also suggest that people use a lens of equity versus equality, because we don't all need the same thing. So equality says that we split it evenly up amongst the population, and equity would say we do resource allocation based on who needs it most. And so I tell my students, if you're in a room with 10 people and you have 10 vials of insulin, do we give one vial of insulin to each person, or do we give it to the person who has diabetes? Obviously the other people don't need it. But if we used a lens of equity, we could undo some of these inequities.
So thank you, Dr. Narruhn, for really taking your time to share this with us and for doing all this work. Your commitment to the community is very obvious and it makes a big difference.
Thank you. Thank you. And thank you for doing all the work you're doing. Universal healthcare is very near and dear to my heart. And, I would love to support you in that work.
Well, this is great support. Thanks for helping us identify the right steps to take as we move to a true universal healthcare system. I'd like to thank each of you for joining us tonight. So thank you very much for participating. I think that we'll call it another step forward in understanding health equity and developing steps, the steps that we can take to achieve universal health care. This is an important part of our work. So thank you all very much for participating.